All right, everyone. Thank you so much for attending this evening. This is the Northern Indiana Hospital Healthy Lifestyle Talks. Today, we're going to be highlighting breast cancer detection and early awareness. We have a couple of different providers here that are going to speak on this topic tonight. So we're really excited to have kind of a comprehensive view of breast cancer, how it's detected, how it's treated, some of the remedies and therapies after patients have undergone medical treatment of breast cancer. My name is Adam Hawkins. I'm an ER physician at Northern Indiana Hospital, and I'm also the chief medical officer. And I'll kind of be serving as your host this evening, introducing our providers. We have kind of a fun panel of 4 different providers who are going to give us talks tonight. So very excited to bring you this information. We're going to start with Stephen Loos. Dr. Loos was born in Phoenix, Arizona, and he performed his undergraduate studies at Creighton University in Omaha. He's a graduate of Creighton University School of Medicine and performed his radiology residency at the University of Colorado Health and Science Center. Before joining Tahoe Carson Radiology, which is our group that provides our radiology services at the hospital, Dr. Loos provided professional services as a staff radiologist at Irwin Army Hospital and Mercy Health Center in Manhattan, Kansas. Dr. Loos, thanks so much for joining us tonight.
Sure, you're welcome.
I think to kind of get things started, do you want to discuss the overall risk of breast cancer to women and how early detection of breast cancer through mammography helps save lives for our patients?
Thanks so much for joining us tonight.
Yeah, absolutely. Well, I mean, what we try to do with breast cancer is to obviously, detect it at the earliest point where it can be diagnosed at a low stage and treated with minimal morbidity and mortality. So basically, we follow the recommendations of the American College of Radiology and the Society of Breast Imaging, kind of a radiology. These are radiology organizations, and we basically we recommend everyone begin screening at age 40 with mammography with average breast cancer risk. And the topic of risk is complicated, but I'll just say that kind of the very latest recommendations from these bodies is that women define their risk early. So they're now recommending that patients, talk to their provider, whoever their primary provider is, and actually establish their risk for breast cancer between the age of 25 and 30. So that's kind of a new thing, because the sooner you can define your risk, obviously, the better off we can go about screening for it and diagnosing it. So, risk is complicated, but basically the main things are, for young women, it would be, do you have a primary relative that has had breast cancer? And obviously the number of primary relatives that have had breast cancer is big. So one primary relative is one thing, 2 is quite a bit different and increases your risk. There are other things that relate to risk, such as your genetics. Women can be tested for the common mutations for breast cancer with the BRCA1 and 2, which are kind of the most well known. There are several others that have been discovered, but those are the big ones. And then your provider can use a risk model. Modeling is done by several ways, but there's something called a Gale model, and you basically just plug in your age, your ethnicity, how if you've had breast biopsies before and what those results were, your family history of breast cancer, and then it basically will spit out a lifetime risk. Most women will have a risk of about 9 to 10% lifetime risk for breast cancer, just general population. So what we're trying to do is define those women who are actually at 20% lifetime risk, which makes them high risk. And then those women, then we want to, like I said, identify early, 25 to 30 years old, and then we can do more than just the regular screening mammography at age 40. In fact, we would go perhaps to start mammography at age 30, and we'd also perhaps start other modalities such as a breast MRI to try to detect cancer early in those folks. So that's kind of a broad swoop of it. But the main thing is women want to very early on define what their risk is, and then we can tailor kind of their risk program in imaging for those people.
Awesome. Thank you so much for kind of giving us the overview of how that works from a radiologist point of view. Could you also kind of elaborate on screening for dense breasts and how that fits into typical screening and mammography?
Absolutely. So that's one of the factors. If you're in what we call a moderately or extremely dense breast tissue pattern on your mammogram, which is about half of women, it's very common to have dense breast tissue. So it makes it a little bit tougher to diagnose breast cancer on mammography with those patients. It's just there's more of it, and it's harder to see through that, even with 3D mammography, which is kind of the standard of what we do now. So for those women, probably the first line that we would offer in addition to mammography is breast ultrasound screening. So breast ultrasound screening and dense breast can really add a bit of sensitivity for detecting masses and something that might be suspicious. So depending on your risk, again, overall, it's not just dense breast cancer, it's all those other factors that go into it. But we would also potentially, we'd want to offer ultrasound to those patients. That's not necessarily going to be paid for by health insurances. So that's one thing to consider, but it might be something that women want to consider either way, just to make sure they're screened well. Not everybody needs it, but particularly if you have some other risk factors, family history, et cetera, and dense breast tissue, you may want to consider that, the ultrasound screening that you could do annually, perhaps, with your routine mammogram.
And Dr. Loos, obviously, cancer of any kind is anxiety provoking, and oftentimes interfacing with our healthcare system at a national level can be onerous and challenging to a lot of our patients and to us as healthcare providers even. Who helps our patients make the decisions about when they should get a mammography based on their risk, if they should start with a mammography or an MRI or an ultrasound? Or is that something that the radiologist is helping our patients with, or is it more primary care driven? And then how do our radiologists kind of fit into that to that pathway with helping our patients along this process?
Right. It's actually kind of multi-pronged, if you will. We're not at the point of care in the primary physician world, so we're not doing that. Hopefully, just through communication with our primary care physicians, we can get a lot of these points across to them so they can counsel their patients appropriately. But when we see patients, often it's in a diagnostic setting, so they have a problem. And we visit with those patients every time, and that's how we communicate to patients and try to educate them that way. Certainly, for instance, up in Carson, we do our Think Pink program, and we have all kinds of informational things for patients that we try to educate them on all the latest recommendations. This is actually, I don't know if this will show very well. But this is actually a really good resource. This is from the National Comprehensive Cancer Network, and that's basically a body that kind of guides oncologists and in the treatment of breast cancer as well as all cancers. And they put out this pamphlet, and it's actually available at, I don't know if people want to write it down, but it's nccn.org/patients. And you can get this for free. And it's actually, I've been through it, and it's actually, you can go through it in about 15 minutes. And it's really a good overall informational booklet on exactly breast cancer screening and diagnosis. And it's written for lay people and patients. It's a really good resource. So I would recommend anybody interested in just learning about this without too much medical, gobbledygook. This is a really good resource.
Awesome. Well, thank you so much. And Barb, maybe we can put that website link in the comments here of the Zoom for our patients listening. And I just want to echo Dr. Loos's sentiments and really encourage patients out there. If you don't know where to start, if you understand, you've heard of mammography before and all, following the guidelines, this isn't something you need to do alone. This is something, ask your primary care physician to help you get started on this journey. Absolutely. And then they're the ones to help kind of navigate you through this process, plug you into the radiologist and the right specialist to help you get the screening that you need. And then if we do find something concerning or cancerous, to help you get to the right specialist to deal with whatever pathology that has been discovered. So I know that can sound very daunting often, but we don't expect our patients to know the latest guidelines or to know exactly where to go when, but have the conversation with your primary doctor. That's the best way to get started. And Dr. Loos, to finish up with your part of this presentation, what is the key message you'd want our audience to take away this evening in regards to screening for breast cancer or early breast cancer detection?
Absolutely. I think it's just know your risk, know what that is. Talk to your primary physician about it. Look at one of the many risk assessment calculators that are out there. But if you don't know, if you don't establish that early, and it's never too late. I mean, you can be older as well and get that risk factor that applies to you, and then that'll just help us in our imaging world to tailor the right screening program for you.
Well, thank you so much. I think I learned a couple of things just listening to you talk, so we really appreciate your time and your insight.
Yeah, you bet.
All right. Next, I'm going to introduce Dr. Eva Wasef. She's our pathologist here at Northern Inyo Hospital. Dr. Wasef graduated from Cairo University Medical School, where she received her diploma of pathology. She obtained her MCR pass degree in London, as she is a member of the Royal College of Pathologists, and completed her residency and fellowship training at USC down in Southern California. And she is board certified in anatomic and clinical pathology. Dr. Wasef has been at NIHD since 2001 and is our pathologist and lab director. Dr. Wasef, I know you're not with us today on video, but you had a presentation that you were going to present our listeners today.
Okay. Well, my involvement with the breast cancer starts with breast biopsies, and usually we get the biopsies from radiology, and we receive it either in the form of core biopsies, that's transcutaneous, always transcutaneous, or through the vacuum assisted biopsies that we have plenty of tissue then. Usually the radiologist biopsy suspicious lesions. If there is calcifications, it's a significant finding, because sometimes calcifications are associated with breast cancer, but not necessarily all the time. It's not necessarily associated with malignancy. Benign lesions can show calcifications as well. So let's start with the first slide. Okay, then there's the next one. Okay, so that's the breast, and this is the nipple, and these are that's the main ducts, the milk ducts that produce the milk into the nipple, and then a series of branching ducts that go into the lobules of the breast. And this is what we get as a needle biopsy. What we examine on the slides is something like that. Needle cores usually varying in length from 0.4 to sometimes 2 centimeters with a diameter of about 1 millimeter. So that's the way it looks grossly, and that's the way it looks under the microscope. And then if there is a malignant diagnosis, we proceed into either partial mastectomy, which is we receive a specimen like that. And when we receive the specimen, it's usually marked with different marking things like a long suture attached to the medial corner, a short suture attached to the superior, so that we orient it. So if we find a cancer, we know if it's close to one margin or the other. And what happens is that we ink the specimen in different inks so that when we look at it under the microscope, it gives you, an idea as to where the cancer is closest to. That's the lumpectomy, and these are the different sutures attached, and that's the markings, red, yellow, green, whatever. And then we slice it serially into several pieces, and we find the lesion. Like here, for instance, it seems like something that stands out a little bit different from the rest of the breast tissue, so that's most likely is where the cancer is. We measure it and we take sections, and we look at the type of cancer and the extent of it. And this is a different kind of specimen, which is the mastectomy. We usually see something like that. There are different kinds of mastectomy. There is a simple mastectomy where the only thing they remove is the breast with an ellipse of skin containing the nipple. And then the modified radical mastectomy is when they remove the axillary tail that contains the axillary lymph nodes. And again, it's examined in the same way, looking for the lesion. And then we determine the different kinds, or the different type of cancer. Different kinds of breast cancer are invasive breast cancer. By far, the majority is invasive ductal carcinoma, which constitutes about 76% of the total number of invasive cancers. And there is the lobular carcinoma, and there is invasive lobular carcinoma, and then there is a mixture of between lobular and ductal. Sometimes it shows both features. And then there are rare subtypes like mucinous, tubular, medullary, and papillary, each one with a different prognosis. And this is the appearance of a normal breast. These are the lobules that I projected in the first slide. There is the lobule in the center, and then there is ducts around it. So this is one of the breast cancers. This is a duct that's distended with cancer and with central necrosis, which you call comedonecrosis. The cells are different in shapes and sizes, and a lot of mitoses. And then necrosis. This is a high-grade intraductal carcinoma. And this is invasive ductal carcinoma. Again, very pleomorphic cells. And then there's, I'll go back a little. Yeah, this is the lobular carcinoma. It's confined within the lobules. That's lobular carcinoma in situ. The lobules are distended with these smaller type of cells than the invasive ductal carcinoma. And then around it, there is invasive small cells, invasive lobular carcinoma, different from the invasive ductal carcinoma where you find ducts with spaces. This is usually solid groups or solid in Indian file pattern, smaller cells, less cytoplasm. And this is a picture of a lymph node involved with metastasis. That's the periphery of the lymph node. And then there is metastatic cancer. It's forming tubules and solid groups of tumor cells. We evaluate the tumor along several parameters. The tumor type, like we mentioned, invasive ductal, invasive lobular, mixed lobular and ductal, mucinous, other rare forms. And the tumor grade, which is determined by 3 parameters. If there's tubular formation, it is better differentiated. Nuclear polymorphism change in different sizes and different shapes of the nuclei. Again, we grade it from 1 to 3, and the tubular formation 1 to 3, and the mitosis again 1 to 3. And then we have a tumor grade, total grade. Of course, the lower the grade, the better the prognosis is. If it's a tubular formation, a lot of tubular formation, then it's a 1, we give it a 1. If there is no tubular formation, we give it a 3, and then in between, we give it 2. Same with nuclear polymorphism and the mitosis. And then the tumor size, we mentioned 3 dimensions of the tumor. And a very important thing is the margin status. And how far away is it from the margin it is. Also the presence of or absence of vascular invasion, and the margin status is, what I mentioned before, the inking of the specimen helps us evaluate the margin, how far does the tumor extend to the ink margin, different cycle margins. And then the presence or absence of vascular invasion, again, determines if the patient, if the tumor is going to spread or has spread already to regional lymph nodes or not. And then assessment of lymph nodes if applicable. And after we have this diagnosis, and we look at the prognostication studies, which are the hormonal studies, estrogen and progesterone receptors, and HER2. And we sometimes do the oncotype DX to find out, the probability of recurrence and the probability of tumor-free survival. And I guess that's the extent of involvement. And this is my family. It has since increased by 1.
Fantastic. Well, thank you so much, Dr. Wasef. If you don't mind, I'm just going to kind of recap Dr. Loos's presentation and then yours as well, just for the audience. So it sounds like if you're a woman and you're wondering how to start this process, the first thing to do is to determine your risk. So reach out to your primary care physician. They'll help you determine the risk. They'll refer you to the appropriate diagnostic imaging studies, whether that be mammography, ultrasound testing, MRI testing. If something is abnormal, then the next step in that process after the imaging study is to get some sort of tissue sample or biopsy. And there, as you mentioned, there are different ways to do the biopsies. There are different ways to get tissue samples, but the tissue sample is really the way that you make the specific diagnosis about which type of cancer a patient might be dealing with. Is that correct?
That's correct. And there's another thing that I missed to mention is the frozen section applicability of frozen sections. Sometimes the surgeon wants to know if the tumor is very close to the margin or at the margin, so that she or he will take additional tissue to make sure that the margin is free. And the other application of frozen sections is where there's a sentinel lymph node, meaning the lymph node at the gate of the axillary lymph nodes, if it's involved or not. Because if it's involved, usually the surgeon will revert to do a lymph node dissection, axillary lymph node dissection. I'm sure Dr. Olson will expand on that.
Fantastic. Yeah, you know, a lot of times in the emergency department, we have, you know, the unfortunate reality of diagnosing things on CT scan or MRI that look like they might be cancerous. And patients always ask, what are our next steps? How do we treat this? But I think that's the importance of getting the biopsy or getting the tissue diagnosis is without knowing which type of cancer you're dealing with, you won't know your next steps about what type of treatment options are available for you or recommended. So a lot of times I think patients don't have a great understanding of how we go from something that looks like cancer on a diagnostic imaging study to making the formal diagnosis of you have this type of cancer and these are our treatment options. So thank you so much for breaking that down for us and giving us insight into which different types of biopsies are available to our patients and how that helps the care team move forward with the treatment of cancer. And Dr. Wasef, similar to like I asked Dr. Loos, is there one key message you'd like our audience to take away regarding this topic?
Early detection.
Early detection.
Early diagnosis.
Of course. Well, thank you so much again. We really appreciate it.
Sure.
Next up in our lineup is Dr. Cheryl Olson. So Dr. Olson is a board certified general surgeon with expertise in breast surgery, general surgery, laparoscopic surgery, and robotic surgery. During her medical education, she served a 2-year tour aboard the USS Simon Lake during Desert Storm and shares a deep commitment to military families and retirees. Dr. Olson's expertise in care of cancer patients includes state-of-the-art procedures for treating breast cancer, including ultrasound-guided biopsy, breast conservation, and the use of accelerated partial breast radiation catheters. All care she provides is highly specialized and tailored to the unique needs of the patient, which may include nipple and areola sparing, mastectomy, followed by immediate reconstruction, which are coordinated with an experienced plastic surgeon. Dr. Olson is a member of the American Society of Breast Surgeons, the primary leadership organization for general surgeons who treat patients with breast disease. She has served as the past governor of the American College of Surgeons. Dr. Olson, thanks so much for joining tonight.
Thank you. Nice to be here. I think Barbara has some slides for us, and we'll kind of talk a little bit about kind of a recap probably of what everyone else has talked about. But yeah, I've been coming here to Northern Inyo for a little over 2 years, 2.5, and it's really been a pleasure and a good experience working with all the people here. So let's go to the next slide, Barbara. So Dr. Loos talked about the risk factors, and I think risk factors are something that's pretty important. Most women should get their mammogram by 40, but if you have one of those families where there's a lot of breast cancer, or your mom or father were diagnosed with breast cancer, you should start getting your mammograms 10 years earlier than that. So if your mom was diagnosed at 42, 43, then you should really start your surveillance earlier. And the best person to do that with is your primary doctor, your OBGYN. Obviously, mammogram is our first most efficient modality to detect breast cancer. But when you're younger, your breasts look different. They're much more dense. And so it's harder to find a cancer. Sometimes women will come with a palpable lump. We can't see anything on a mammogram, so we look with ultrasound. Sometimes even we can't see it with ultrasound. So then in those higher risk patients, we do get an MRI, which can help us. That can be a double-edged sword because MRI kind of detects a lot of stuff. So those are the main modalities in which we use to find breast cancer. I do see women who come with thermograms or a test that detects heat, and it shows some interesting information, but it's not really something that we can use to definitively say, this is an area of abnormality and this is how we could biopsy it. We don't have any way to use that modality to make a diagnosis. Why don't we go to the next slide, Barbara, and see what else I had on there. So I kind of went through that. So there's a lot in the media about risk and genetic mutations. And there are definitely families who have BRCA1 or BRCA2 mutations. There's other mutations that are critical, like CHEK2, PAL2. And those are genes that associate breast cancer with another type of cancer. And so those are patients that we definitely want to know about early on. It's most important for the family member who has the cancer to get the genetic testing. And then once that's been done, then we can decide who in the family should be tested. There are families who have a familial inheritance pattern, meaning grandma, mom, and then the daughter has breast cancer, but they've been tested and there is no gene. So we say that those are patients who probably have some genetic connection, but we just don't know which gene it is yet. So that's yet to be discovered. There is a role or a predominance of breast cancer differences with your ethnicity. Certainly, there are a higher incidence of breast cancer in Black women. And when you take it a little bit further and look at the physiological factors, obesity definitely also shows a higher rate of cancer. So we would expect a Black woman who's obese to have a much higher rate of breast cancer or risk of breast cancer compared to a thin white woman. You know, breast cancer doesn't avoid any particular ethnicity. We see breast cancer in all racial backgrounds. So we just see a little bit higher rate in certain groups. Physiologic factors, I don't know that these really matter so much anymore. I see so many women who get breast cancer at all ages. It used to be that younger age of starting your menstrual cycle was a higher risk for breast cancer because of the hormone levels. Certainly women who have their first child or don't have children until late are at a higher risk for getting breast cancer. Breastfeeding is a protective feature. And again, late menopause is a higher risk because of the estrogen levels. Let's go on to our next slide. So a lot of people ask me, you know, when they get diagnosed with cancer, well, what did I do? I'm so healthy. I eat clean, I exercise, I feel great, and I still got breast cancer. And, you know, unfortunately, there are some things that do impact our getting breast cancer, but it's so multifactorial, and it probably takes advantage of some genetic imperfection in some cell line, but certainly toxic exposure, proper radiation treatment. We do a higher incidence in young women who had Hodgkin's lymphoma and got radiation to, we call it mantle radiation. They get radiation to the clavicles and the central chest. Those women usually get a breast cancer that's included in that field of radiation. We typically advise our patients to watch their alcohol intake once they've had cancer. I think I'd be hard pressed to say that alcohol really has a causal relationship, but certainly excess. My motto to patients is usually moderation is critical in all things. So take it easy on the alcohol. Again, I mentioned the obesity, we do see that. And one of the key things about obesity is we believe that the fat cells can hold on to estrogen. So when you're a little bit heavier, carrying a little bit more weight, you actually have higher estrogen levels, which if you then develop an estrogen positive cancer, that has an effect on getting that to grow faster or just allowing you to develop it. We also see a lot of women on hormone replacement therapy after menopause, after a hysterectomy where the ovaries are removed. And that can certainly play a role. Some women who undergo hysterectomy very early in their 30s and go on hormonal supplements. I think right now, I think medicine has really taken a look at how we dose our patients on hormone replacement therapy. And I see women coming in on less medication, smaller doses. When my mom had her hysterectomy at 37, she was put on a high dose of estrogen, like 1.25 of Premarin, and she took that for 30 years before she developed breast cancer. So that's definitely a risk factor. I think women now are on much smaller doses. We've realized that the transdermal or a skin patch is much safer than an oral pill. Other things, exposure to DES, that's diethylstilbestrol in utero, can have some increased risk. And tobacco, I don't know that there's a direct line of tobacco to breast cancer, but tobacco does a lot of bad things to your body that then become an issue if you happen to develop breast cancer and need to be treated. Let's go to the next slide. So the detection modalities, the thing that you have available to yourself most readily is your hands and your breast, and you should do a breast exam once a month. During your menstrual cycle may not be the best time, but say the week after would probably be ideal. They do have shower cards that you can put in your shower just to remind you. Shower is an exceptionally good time to do an exam because your fingers wet a little bit easy. I think you may be able to feel things a little bit better. Physician physical exam is really, really important. I have so many patients who go get their mammograms and they say, oh yeah, my mammogram's good. See you next year. It's like, whoa, wait a second. You have to come in. You have to be examined. So whether that's your primary, whether it's your OBGYN or your internist, somebody just needs to examine your breasts once a year. The mammograms, I think our mammograms have come a long way. Dr. Loos can probably talk about that, but we now have high definition sort of 3D tomosynthesis. So rather than having a two-dimensional structure of a three-dimensional object, you can sort of get close to having almost like a movie picture going through the breast and see things that we wouldn't otherwise see, or clarify things that might cause you to have to come back and get a couple other views. And then there's MRI, which is most helpful in our young, dense breasted patients, but we get MRIs on almost all of our cancer patients who can be in the machine just because we find more extensive cancers, we find satellite nodules, or sometimes we find a cancer on the other side that changes how we manage things. So MRI has become a very important part of our breast cancer detection. So things to look for on self-exam, everyone, you know, a lump is probably the most obvious, but you can also just notice a skin dimple or a bloody nipple discharge. I recently saw a lady who had just a skin sore on her nipple, it just wouldn't heal. She was putting antibiotics on it and it just kept coming, it just would never heal. And so we did a biopsy and it turns out that it was the carcinoma in situ. So not an invasive cancer, but it was cancer lining the ducts. But we then had to remove the nipple and a little bit of her breast tissue, and she'll go on to get radiation. The other thing that you can notice, sometimes you just notice that your breast doesn't look the same. It's swollen, it might be red. If it looks like an orange peel, that's really concerning. You need to get yourself to the doctor immediately if that's the case. Redness could be an infection, but if you're in your 50s or 40s and you're not nursing, that's an unusual finding. And the other thing is sometimes people notice a nodule or a lump in their underarm, which can be a cancer. So this is a patient with a very swollen breast, little bit of a redness around the nipple. And this was diagnosed as inflammatory breast cancer. Inflammatory breast cancer is something that people hear about. Many, many women are very, very concerned, but it's also very rare. It's a very small number of patients who get inflammatory breast cancer. But it's a clinical diagnosis, which we then have to confirm with some tissue sent to Dr. Wasef over in pathology. But inflammatory breast cancer is usually an advanced, very rapidly progressing cancer and can look a lot like an infection. Next slide. This is a worse picture of the same thing, more advanced inflammatory breast cancer. Next. So again, I think that the take-home message is early detection can really make a difference in whether you have tumor in the lymph nodes, whether you need chemotherapy, whether you can have a lumpectomy radiation, or whether you need a mastectomy. So getting in early, getting those mammograms is really a key part of taking care of yourself. This is just a little staging guideline, probably a little too much for this talk, but 100% survival if you're a stage 0, which is the carcinoma in situ. If you have a stage 1, which is no lymph node involvement and a small, easily resectable tumor, your survival is 98%. If you're a stage 2, your survival goes down a bit, and stage 3, even so more. But if you're already a stage 4, which is meaning the tumor has spread beyond the lymph nodes or those first lymph nodes in the underarm, they can be in the liver, they can be in bone. That's a stage 4, and the survival there is much, much worse. It does depend on what type of cancer you have. Let's see what the next slide has. What time is it? Guess we can keep going. So one of the other things to talk about, and patients often are curious, well, what stage am I? And so our staging system is made up of the size of the tumor, the size, or whether lymph nodes are involved, and whether there's any distant metastasis. So the majority of our patients are stage 1. Sometimes you can be a stage 2 because the tumor is larger, lymph node involvement. You could have a smaller tumor and be a stage or a T1, have lymph nodes involved, and therefore you'd be a stage 2. It gets a little complicated. I just pretty much remember N+1, so node +1. So if your node 0 and you have a T, you're a stage 1. If your node is involved, you're probably stage 2. Next slide. So this just goes through this a little bit more, but typically our tumors are smaller. We don't see too many involving the skin, but that does happen occasionally. Next slide. This is just a little bit about lymph nodes. The majority of lymph node involvement is the underarm or axillary lymph nodes. But one of the things we do look for in those MRIs, and we can detect lymph nodes that are behind your sternal bone, which are called internal mammary nodes. Sometimes those can be involved and really change the stage and kind of how we approach things. And you can have nodes up by your collarbone, which also increases your stage quite a bit. Next slide. So obviously breast cancer can go just about anywhere: bone, liver, brain, lung, can go to the ovaries and the peritoneal cavity. That's pretty rare, but can see that occasionally. So the other thing, the lingo that we talk about with breast cancer, and Dr. Wasef mentioned, are the estrogen receptors and progesterone receptors. Those are the hormone receptors. And those really lend themselves to helping us treat breast cancer. So if the estrogen receptor is positive, then when it comes time to treating the patient, we can actually block estrogen or downregulate estrogen production. And so we basically prevent tumor cells from growing. The HER2 status is a little bit more complicated. HER2 is actually a gene that's manifest in the tumor. And so if the HER2 gene is turned on, the cells respond differently, and we can actually turn those off with a medicine called Herceptin or Perjeta. So patients who have a HER2 positive status at the beginning, those patients typically get chemotherapy first before surgery. So just a little fun fact there. Next slide. So that's just a little more staging. It's probably a little too busy. And then, so the treatments, typically surgery, it's just a matter of what order do we do things. Do we do surgery first, or do we do neoadjuvant chemo, trying to downsize or spread before surgery? Then we do the surgery. Then we decide whether we do chemotherapy or hormone suppression. One of the tests Dr. Wasef alluded to, called the Oncotype DX, is something that's pretty widely used now, where we look at the patients that are hormone receptor positive to see if there's any benefit to getting chemotherapy as well. So there's a predicted survival with hormone suppression, but then would there be benefit from the chemotherapy? So Oncotype score of 25 or less, no chemo. 26 or higher, you get chemo. And then radiation is used as an adjuvant treatment. Sometimes in the breast, if we save the breast, women will get radiation to the breast. If they have a very advanced stage, they may need breast and axilla radiation. If they've had a mastectomy and had a very advanced case, they may need chest wall radiation. So that's a very helpful thing. Next slide. So lumpectomy is also known as a partial mastectomy or a segmental resection, where we just remove the tumor with a small rim of normal tissue around it. And that is typically followed by radiation. Mastectomy is removing all the breast tissue. It can be done by removing the nipple and the areola. It can preserve skin, but only take the nipple and the breast tissue. Or we save the nipple and do a reconstruction. Usually if we save all the skin but take the nipple, they're still getting a reconstruction. That is something that we can't do here in Bishop because we don't have a plastic surgeon here all the time, and I'm not here but once a month. So it becomes more challenging, and patients need a higher level of care if they wish to have a reconstruction. So those patients that come to Bishop, we usually end up referring them to a center where they can get the plastic surgery team all in one place. Next slide. The lymph node management. Lymph node management has actually changed. At the beginning of my career back in the 90s was when we started doing sentinel lymph nodes. And basically that means that we label the lymph nodes that drain the breast first. So there's a critical key 1 or 2, sometimes 3 lymph nodes. And if we remove those and there's no cancer in them, then we know that there's no cancer there, and we can be confident that the remainder of the lymph nodes are negative. The reason this is important is because patients have less side effects. Arm swelling is much less common, and there's less troubles with shoulder range of motion and that kind of thing. If we have to do a complete lymph node dissection because sentinel nodes are positive and the patient got a mastectomy, there is a much higher risk of lymphedema, about 30%. I should probably stop here. Is there another slide? Oh, perfect. That's the end. So lymphedema is something we're fortunate to have an expert to be on next, I think.
Well, thank you so much, Dr. Olson. Again, I really appreciate the order that we've gone in tonight. We've gone through early detection with Dr. Loos, diagnosing with Dr. Wasef, and now some of the treatment options with your talk. And I think your discussion of the treatment options reveal that this is nuanced. And again, we can't help treat patients without knowing what's going on, and we can't know what's going on without the early detection. So this all really starts with early detection, early detection, early detection. So thank you so much. And I was going to ask you a big takeaway message, but I think it's probably going to be early detection, unless there's something else that you want our patients to take away from your talk.
Well, the only thing I would say is be your own advocate. If you feel a lump or feel like something's not right, and somebody says, "Oh, it's nothing, don't worry about it," but the abnormality persists, get a second opinion. The way that women develop advanced breast cancers is either denial from themselves or maybe getting misguided or overlooked. And so at least get another opinion about what's going on and is there something wrong. So I see a lot of those patients and reassure them, thankfully, there's a lot of lumps out there that aren't cancer, but it's very important if you think there's something wrong that you follow through and be your own self-advocate.
And I think that point was made very clear in the slide where you showed, I think, stage 1, the survival rate was 98%, I believe. And then stage 4, the survival rate drops down all the way to 16%, which is obviously a catastrophic difference. So thank you so much for reiterating, be your own advocate, call your primary care provider, get the right detection testing, and so that you can advocate for yourself and your health. Thank you, Dr. Olson.
Thanks.
And then our last talk tonight is going to be from one of our physical therapists, Dana Georgeson. Dana moved to Bishop from the Central Valley, where she joined Northern Indiana Healthcare District in 2022. With expertise in treating patients with lymphedema, Dana earned her certification as a lymphedema therapist, or a CLT, in 2010. Dana is highly skilled in working with patients in the acute care setting. She also has clinical interest in wellness, balance and fall prevention, pelvic health, and orthopedics. Dana is one of our physical therapists who specializes in treating lymphedema, which is a complication of some of the treatments that Dr. Olson was talking about. Dana, thanks so much for being with us tonight.
Hi, thanks for having me. Yeah, so one of my primary specialty is lymphedema, and I do have to say that it's very impressive that Dr. Olson is so supportive of physical therapy, and especially the early detection and treatment of lymphedema. As she mentioned, one of the secondary fallouts, I guess, of undergoing treatment for breast cancer is potentially and unfortunately lymphedema. So your lymphatic system is pretty incredible, really. It's basically our immune system, and your lymph nodes do a really fantastic job of identifying invading bacteria and viruses and identifying them, eliminating them, and just taking care of the problem, basically your garbage system. And when you lose like a sentinel lymph node, it might be your primary one that's doing most of the workload to manage the lymphatic fluid in your system, in that arm, let's say. And a potential problem is some swelling that occurs in that arm. And there is a treatment, and that's what I do to help contain it, manage it, and keep that arm functional. Another thing that she'd mentioned along with lymphedema is limited range of motion, strength, shoulder pain from either a large lumpectomy or mastectomy. A lot of that chest wall anatomy can be involved and be very restrictive. So you lose a lot of functional use in your arm, making it difficult to reach overhead, to wash your hair, to put on a t-shirt, reach behind the scene till kids stop biting. So we can also help prevent limited use and keep the use of your arm after you undergo treatment for your breast cancer, whatever you and your surgeons decide that needs to be. The importance of, as we've been talking about, early detection, but also early treatment of lymphedema is when that system isn't working very well, you're at risk of increased infections. because that lymphatic system removes cellular waste and bacteria from a cat scratch or working in the garden. If that bacteria isn't moved through your lymphatic system and that bacteria isn't killed by your lymph nodes, that those invaders can sit there and lead to infection, and that can be catastrophic. So early management and understanding of how that lymphatic system works and then how you can keep it under control is essential for whole body health. Anyway, that's a very basic summary of what I do. And I am in this setting at this location, this hospital, very supportive of early treatment of lymphedema. And as a provider, I'm super thankful for the that leaning into those therapies so that my patients have the best outcomes. Our patients have the best outcomes. The community has optimal health and wellness, which is what we do. If anybody has any questions about what that entails, Dr. Olson knows how to reach us. The hospital knows where we are. If you have any questions about how your arm is working or what you suspect, if you suspect that you might have lymphedema, which would be swelling and a feeling of heaviness in your arm, typically not very painful, grossly in your arm, maybe at your surgery site or something like that might be painful, but the swelling in your arm or your hand typically isn't painful, just a feeling of heaviness. We can get you set up. So please feel free to contact. Barb might be able to list our contact information on a screen and we can get you in. I'm super happy to see you and get you going with whatever you need, is if it's musculoskeletal or lymphedema, but there's hope, there's treatment. We can get you back going again with that arm. Thanks.
Thank you so much, Dana. Is there anything you'd like to have our audience take away, one big message from your standpoint regarding the treatment of patients suffering from lymphedema as a result of breast cancer?
Honestly, the early treatment, and I really appreciate what Dr. Olson said. Honestly, be your own advocate. A lot of providers, a lot of primary care providers might not recognize or be aware that there is treatment for lymphedema. That occupational therapy and physical therapy, we can both be certified in lymphedema. I'm not aware, I might be wrong, I'm not aware of another provider in the Owens Valley that does lymphedema currently. So I'm here, but there's also, of course, the bigger cities, but there is treatment for lymphedema. If you have to go up to Reno or Carson City for something and you're always up there, like advocate to find out what your options are wherever you need to go, however that works for you. But truly, you know something's wrong with your body. You know what it feels like. You know what normal is. You know yourself, and you can lean into advocating for yourself a lot. That, especially with lymphedema, especially because a lot of providers, it's not a common thing. It's becoming more understood, but it isn't like I would call mainstream yet. So
awesome. Thanks so much, Dana.
Yeah.
The big takeaway that I've had is just how fortunate we are to live in a community like we live in that's amazing. That's also very isolated and far away from big cities, but we have the resources at our hospital, from primary care through diagnostic imaging and radiology, through diagnosis and pathology with Dr. Wasef, to certain treatment options with Dr. Olson, and then for managing some of the complications in life after the treatments with Dana and our rehabilitation team. First of all, I don't believe there are any questions in the chat, but one last ask from our audience if there are any questions for any of our panelists tonight before we kind of close things out.
Actually, Dr. Hawkins, I have a question on YouTube for Dana, and it was, how do you approach courting?
Oh, so that that's more of like a musculoskeletal thing, and that is really, really getting in on a gentle range of motion program early on. When you're cleared by your surgeon, whatever, because there's different stages of tissue that can be involved. Sometimes that's after radiation, and that can be quite painful. Yeah, just gentle range of motion, really there's a lot of forward leaning and a lot of tightening of tissue that is secondary to the treatment that you undergo. And as much as you possibly can, posture and an early range of motion program can prevent quite a bit. But sometimes there's just tissue changes that happen that we just have to gently address as they come up. But range of motion and making sure that you're maintaining strength for musculoskeletal balance when one tissue tends to be targeted.
And Barb, are there any other questions on?
I do not have any other questions. Does anyone out there, would they like to unmute and ask a question?
Great. Well, thank all of our panelists so much for your time this evening. I certainly learned a lot. Not all of this interacts with my clinical world in the emergency department. So thank you for your time and educating all of us. And again, early detection, if you're confused about where to start, I think the best thing you can do is just pick up the phone and schedule an appointment to talk to your primary care provider about where to start along this journey. And thanks so much to Barb Lahan for setting this up and for always organizing our healthy lifestyle talks. And I hope everyone has a great rest of their week. Barb, I think this can be viewed on YouTube if anyone missed it. Is that right?
That
Wants
is
to pass it
correct.
along.
That is correct. It takes about 2 hours for it to process, but it should be available.
Great. Well, with that being said, thank you all so much and have a great evening.
Thank you.
Thank you.